للمؤتمر الاسمي بتاعنا العاشر، والحقيقه احنا بنفخر بان احنا المؤتمر ده بقى يعني بقينا حريصين عليه، وبقينا يعني نقبل عليه كلنا وبنشترك فيه بقلب وبحماس. والحقيقه الفضل في هذا الموضوع بدايته كان مع الاستاذ الدكتور محمد ابو الهدى، هو اللي كان له الفضل ان هو اقتنع بالفكره دي، وهو اللي دخلها لنا واستمر الموضوع من ساعتها. النهارده طبعا يسعدني ويشرفني وجود معايا اخواتي وزمايلي الاستاذ الدكتوره امال الجنزوري رئيس السابق لقسم الروماتولوجي اند ريهابيليتيشن، والاستاذ الدكتور عمرو شفيق استاذ الكلينيكال اونكولوجي. والحقيقه انا بعتبر وجودهم معانا دايما في يعني اضافه للاسم اللي بنسمع منهم اسئلتهم احتياجاتهم مننا ايه، ونحب دايما نعرض عليهم اذا كان في حاجه جديده بنقدمها. نحب ان هو دايما يبقوا معانا ويطلعوا معانا ويبقوا دايما يشاركونا اذا كان في حاجه جديده بنعرفها، واذا كان في حاجه هم عايزينها ومحتاجينها مننا او استفسارات مننا، تبقى دايما يبقى في يعني كوميونيكيشن بيننا وبينهم. فانا سعيده بوجودهم معانا، وان شاء الله كده تبقى جلسه فروتفول وساتيسفاينج للناس كلها. اتفضلي يا دكتوره.
صباح الخير. ألف مبروك على المؤتمر الرائع ده والتنظيم الهايل. والحقيقة حابة أشكر دكتور محمد أبو الهدى ودكتورة هالة أبو سنة. دكتورة هالة أبو سنة أخت عزيزة جدا عليا، يعني دايما مع بعض في مؤتمرات الروماتيزم، وهي متميزة في كل شيء، وأبقى سعيدة جدا وأنا معاها، وبشكرها على الدعوة الكريمة دي. ودكتورة أماني راشد رئيس القسم، وطبعا دكتوره منى على تعبها ومجهودها وطلعت روحها عبال ما رديت عليها. وان شاء الله هتبقى يعني ساينتفك سيشن هايله. وانا عن نفسي انترستد جدا بالذات جزء البات سكان والام ار اي في المايوسايتس، الحاجه اللي ريليتد لينا. فدكتوره منى تستعد الاسئله كتيره جدا، وهنبتدي باول سيشن. دكتورة عبير جمال تتفضل. هتكلمنا النهارده على correlation between diffusion weighted chest MRI and PET scan newly diagnosed non-small cell lung cancer. اتفضلي يا دكتور.
Good morning. Today I'm going to present my thesis about correlation between diffusion-weighted MRI and 18F-FDG PET-CT in newly diagnosed non-small cell lung cancer in a nutshell. Till this day, lung cancer remains one of the leading causes of cancer-related global mortality, with non-small cell lung cancer account for more than 80% of the cases. PET-CT is currently the gold standard for initial staging and restaging of lung cancer, as it can identify distant and nodal metastasis, integrating metabolic and anatomical data with a quantitative marker, the maximum standardized uptake value. MRI is a sensitive discriminator between benign and malignant consolidation and can be used to diagnose lung malignancies and provide information about tumor morphology. Diffusion-weighted MRI uses the random mobility of water molecules in biological tissue with a derived quantitative measure of the transport of these water molecules, which is the apparent diffusion coefficient, the ADC value. Lower ADC values are noted in malignant lesions compared to benign lesions due to restriction of the water molecules' mobility. In malignant tumors, the increased cellular density restricts water diffusion in the interstitial space, resulting in lower ADC values. Hence, in non-small cell lung cancer, diffusion-weighted imaging has been reported to reveal information about tumor cellularity and aggressiveness, helping to predict tumor invasiveness even at early stage. Since SUV and ADC values both reflect information about tumor behavior, with the SUV displaying metabolic tumor activity and the ADC quantifying tumor cellularity, a correlation between these two quantitative markers is expected. Our study aimed to correlate ADC assessed by diffusion-weighted MRI and metabolic activity determined by SUV max in local and nodal staging of newly diagnosed non-small cell lung cancer. This was a cross-sectional study carried on 21 pathologically proven cases of non-small cell lung cancer at our MRI and nuclear medicine unit, Ain Shams University hospitals. Regarding patient selection, inclusion criteria included adult patients with pathologically proven non-small cell lung cancer or lung masses diagnosed by CT proven later to be non-small cell lung cancer. Patients subjected to chemotherapy, radiotherapy, or surgery were excluded, as well as patients with contraindications to MRI or PET-CT, and patients with lung masses other than non-small cell lung cancer. Approximately 1 millicurie per 10 kg of FDG was injected intravenously with saline infusion. Then the PET scans were obtained, followed by contrast-enhanced CT scan for attenuation correction. MRI of the chest was done in the same day just before the PET-CT examination in our 1.5 Tesla high-field MRI machine with a dedicated torso coil placed on the chest wall. Axial diffusion-weighted images and T2 images were obtained in addition to coronal T2 in some cases. The expected respiratory motion artifact was accommodated by respiratory gating with a respiratory sensor kit held around the patient's abdomen for breath synchronization. SUV max of the primary mass lesions and mediastinal lymph nodes were calculated for each patient according to their body weight. ADC maps were reconstructed automatically for each patient using the standard software of the MRI unit. Regarding the results, our study included 21 patients who were pathologically proven to be non-small cell lung cancer, 19 males accounting for the vast majority of patients with 90.5%, and only 2 females accounting for 9.5%. With age ranged from 37 to 84 years with a median of 61. Adenocarcinoma with the most common histological subtype with 52.4%, followed by squamous cell carcinoma with 47.6%. Regarding the correlation between ADC and SUV max of primary mass lesions, we found a statistically significant negative correlation between SUV max and ADC minimum, mean, and maximum with Pearson correlation coefficient and p-values as shown. We also found a statistically significant negative correlation between SUV max and ADC minimum, mean, and max of mediastinal lymph nodes with the following Pearson correlation coefficient and p-values. Now to some of our cases. Case 1 with a 60-year-old male patient with right upper lobe mass proved to be adenocarcinoma. PET-CT showed right upper lobe mass achieving SUV max of 18.2. Axial T2 and diffusion-weighted images with corresponding ADC map showed diffusion restriction of the mass with ADC values of 0.8, 1.8, and 0.6 for the mean, max, and minimum values respectively. Case 2 of a 59-year-old male patient with squamous cell carcinoma of the right lower lobe with mediastinal lymphadenopathy. PET-CT showed right lower lobe mass achieving SUV max of 22.3. Axial diffusion and ADC maps showed ADC values of 0.7, 0.9, and 1.2 for the minimum, mean, and maximum values respectively. Subcarinal mediastinal lymphadenopathy were noted in the same patient achieving SUV max of 19 with ADC values of 1.09, 1.1, and 1.2 again for the minimum, mean, and maximum values respectively. Case 3 of a 64-year-old male patient with poorly differentiated squamous cell carcinoma with right apical mass. Axial and coronal PET-CT images showed large apical mass achieving SUV max of 29.6 with areas of central breakdown. Axial and coronal T2 images of the same patient showed the mass invading the anterior chest wall with areas of breakdown. Restricted diffusion of the mass was noted with higher ADC values in the center corresponding to the breakdown. Case number 4 of a 52-year-old male patient with left hilar squamous cell carcinoma. Axial CT in soft tissue window showed left hilar mass merging with the lingular collapse. PET-CT delineated the left hilar mass which achieved SUV max of 18 with non-metabolically active adjacent collapse. Axial T2 of the chest showing the left hilar mass with diffusion in ADC maps showing restricted diffusion in the left hilar mass with facilitated diffusion in the adjacent lingular collapse. Finally, case number 5 of a 72-year-old female patient with adenocarcinoma of the left lung. PET-CT showed left upper lobe mass achieved SUV max of 9 with diffusion and ADC maps showing restricted diffusion with ADC values of 0.6, 0.9, and 1.3 for the mean, minimum, and maximum values respectively. Adjacent metabolically active pulmonary nodule was noted achieving SUV max of 4 with restricted diffusion and ADC values as shown. Conclusion. Non-small cell lung cancer is one of the leading causes of cancer-related mortality each year, which makes it crucial to early diagnose patients, especially those who may have an unfavorable outcome of the disease, to modify their treatment plan. We found a statistically inverse correlation between SUV max of PET-CT and ADC of diffusion-weighted MRI in all primary mass lesions as well as mediastinal lymph nodes, regardless of their histological subtype. We conclude that ADC values might act as a new prognostic tool due to its significant inverse correlation with SUV max in local and nodal staging of non-small cell lung cancer. Thank you.
بنشكر دكتورة عبير جدا على المحاضرة القيمة، ودكتورة هالة عاوزة تسأل بعض الأسئلة.
شكرا يا دكتورة عبير للشغل بتاعك جميل. انا بس كان نفسي اسال، هل انت عملتي فولو اب للعيانين بتوعك دول؟ يعني هل مثلا استفدتي من الاي دي سي فاليوز دي ان انت لو عملتي فولو اب هل مثلا بتتغير النتيجه بحيث يبقى انت ده عامل مساعد مع البيت سي تي ان احنا تو ايفالويت البيشنتس دول؟
هو الحقيقه السبيكترم بتاع الثيسيس بتاعي كان النيولي دايجنوز بس من غير الفولو اب، لان في رساله ثانيه دلوقتي معموله على الفولو اب بتاع البيشنتس، وفيهم بعض من البيشنتس بتوع الرساله بتاعتي.
وفعلا بتفرق يعني الاي دي سي فاليو بتتغير من بعد الفولو اب؟
طبعا
نتيجه للتريتمنت يعني.
طبعا.
تمام. انت عملتي كام حاله؟
21 حاله.
21 حاله. يبقى انت حاجه بقى تكملي بقى ان شاء الله البحث الجميل ده وتعملي فولو اب للعيانين بتوعك. بشكرك شكرا جزيلا، متشكره جدا.
صباح الخير على حضراتكم جميعا.